Everyone. Great to see everybody here. Last night was really stimulating, but I think today we're going to have a huge number of things to discuss, and we want to get you out before the ball game starts. So without any further ado, really, first of all, I want to welcome you here and thank you for coming. We have a very diverse array of people here in the room, different organizations, different interests, but I think we all passionately care about HIV prevention and improving the lives of members of our various communities. So I just want to start off our conversation, then we're going to have two framing talks by very distinguished and very articulate colleagues. So just for those who are not familiar with Fenway, where we are right now, Fenway is a federally qualified community health center. We were founded in 1971. This is the West Fens, and the other side of the ribbon of trees there is the East Fens. So we were originally started on the other side of the Fens near Symphony Hall. Because of the diverse neighborhood that we lived in, there were a lot of gay men and lesbians in the community, some of whom were in leadership positions of Fenway. And Fenway responded early on to the HIV/AIDS epidemic. Okay. Really? I'm mic'd, and miracles of modern technology. Thank you. Thank you, Amy. Okay. All right. So we're a federally qualified community health center, founded in 1971. The original health center was on the east side of the Fens. The neighborhood is very diverse. Fenway's community health center was not founded as an LGBT community health center, but as a neighborhood health center with a large LGBT population. And so when the HIV epidemic started, we responded. At the present time, we've got about 22,000 patients in primary care, about 2,000 people living with HIV. About half of our patients are LGBT. In responding to the epidemic, we started a research program, which has now morphed into the Fenway Institute, which also does education and dissemination. We're involved in a number of the NIH networks, including the Adolescent Trials Network and several of the prevention trials networks. We also have a variety of investigator-initiated studies in epidemiology, clinical medicine, and behavioral interventions. We have a population center grant, which our colleague Judy Bradford is leading, which is the first demographic center to focus on LGBT population health. And then more recently, Harvey Macedon has been leading our education center, which has received a grant from HRSA to train primary providers around LGBT health. Steve Boswell, who's the president and CEO of Fenway, is the data geek and very interested in electronic health information and electronic health record capture more than 2 decades ago. And so Fenway was one of the first institutions in New England to have a comprehensive electronic health record, which we now participate in 3 NIH and ARC-funded networks that do health service research, and then 1 community health applied research network, the CHAR network, that is HRSA-funded. So our research focus began at the start of the epidemic, and there are many teaching hospitals here. There's Harvard School of Public Health. Many of our colleagues in the academic centers were looking at what's the cause of the infection, how do we treat opportunistic infections. We were seeing a lot of really scared gay men whose partners were sick. They wondered, could they hug, could they kiss, what would happen if they sucked, but the partner didn't ejaculate. So we, very early on, our research agenda was driven about trying to understand how do we prevent HIV. A colleague, Jerry Groupman, who many of you may know more as a writer in the New Yorker now, was a hematologist oncologist, and we were sending all the people with CAPACEs to him. And he got to know Robert Gallo as an oncologist and said, in 1983, Gallo has a test for what he thinks is the virus. You're collecting all these specimens on people where you're collecting all these histories and trying to understand who's at risk and who's not. Let's send him some blinded panels. And that was the first report of HTLV3 infection in New England. We also, very early on, were very interested in issues that were associated with transmission. So a colleague, Deborah Anderson, here, who ran a mucosal immunology lab, started saying, can you send us semen specimens and can we try to understand what are the factors associated with infectiousness? So This is the photomicrograph of semen from an HIV-infected individual. The little blue dots are spermatozoa. The big blotchy red dots are genital white blood cells. And the modeled background is seminal plasma. So very early on, we were doing translational research. And this first study was published more than 20 years ago now in the Journal of the American Medical Association. We actually found, because AZT was finally available, that people who took AZT, we had specimens before and after they took AZT, we looked at HIV in their semen. The HIV in the semen almost disappeared, didn't completely disappear, but went down dramatically. And that really has been sort of one of the first reports that informs kind of our conversation today, that we have antiretroviral therapy. You know, if you're an infectious disease specialist, you think of ending any epidemic as three major domains. You can alter infectiousness, you can alter host susceptibility, and that's where a vaccine would come in, or you can alter behavior. With HIV, we have to acknowledge the fact that behavior is pervasive and really important for all of these behaviors, because if people don't trust the medications or don't trust the providers or are not adherent, none of these strategies are going to work. Even an uptake of a vaccine, people may not line up to take the vaccine if there's medical mistrust. So where are we with this whole paradigm of treatment as prevention and pre-exposure, post-exposure prophylaxis? Well, Everett Rogers in 1962 posited a theory of diffusion of innovations. He was an agricultural sociologist, but I think it's very relevant here. The first people are the innovators, and we're somewhere between the innovators and the early adopters. And really the question for us as a group today, as many of you who are leaders of organizations, thought leaders are, how do we diffuse the innovations that we have now that have good evidence to be able to be normative and make sense in people's lives? And just to put this in perspective, we now think of giving antivirals for HIV-infected women to prevent mother-child transmission as a norm. Well, the ACTG 076 study, the first one, the data were available in the early 90s, but and the gray zone, you can see when the data were first published in the New England Journal, and you can see that it took a while to ramp up over many years, and people now say, well, it's a no-brainer to help prevent mother-child transmission. So these things don't happen overnight, so I'm not terribly pessimistic that PrEP or that wider treatment isn't going to make sense, but how do we do it right, and how do we respect community norms and values is a really important thing. So I just want to thank my colleagues at Fenway, particularly Sean Cahill, who really did so much of the legwork, and Andrea Karras, who helped make many of the arrangements. And without further ado, I'm going to introduce both of our next speakers, who are really quite incredible people who are going to be presenting sort of the knowledge base for these issues. We have Trip Gulick, and Trip is from Cornell Medical Center. He's the chief of infectious disease. Trip has been one of the foremost leaders in terms of thinking about antiretroviral therapy and in clinical research, and has done some of the seminal studies of HIV treatment. And more recently, he's moved into the field of treatment as prevention and the field of chemoprophylaxis with a profound understanding of how you use antivirals selectively. And he's the protocol chair of a study in the HIV Prevention Trials Network, HP 10069. Our other speaker, Steve Safren, is a professor at Harvard Medical School. He's chief of the behavioral therapy program at Massachusetts General Hospital. He's also our senior behavioral scientist here at Fenway. And Steve has developed over several decades now several evidence-based behavioral interventions to increase medication adherence, to decrease risky sexual behavior, and has mentored a team of people doing work with substance use interventions, as well as interventions with other key populations, including transgender women. So without further ado, we'll have Trip and then Steve, and then we will have some time for Q&A.
Thanks, Ken. I'm really pleased to be here today. I really like the way you framed this. This is a conversation that we're having today, and it's really a critical conversation, I think, as to how we get the message about ART as prevention out there. Ken asked me to frame the issues from the biomedical point of view, and so I will try to do that. The first thing is, what's the rationale for ART as prevention? And it's simple. The idea is that having HIV drugs present at the site of exposure should reduce the risk of infection. Now, this is not a new idea in HIV. In fact, Ken's already mentioned the first thought with using treatment for prevention was really to try to prevent an HIV positive pregnant woman from passing to her child. And so we go all the way back to the early 1990s, and Ken mentioned this study from the AIDS Clinical Trials Group. A single drug at the time, AZT alone, was given in a study, a randomized study. Women who received it passed HIV to their child only 8% of the time. Pregnant women who received a matching placebo, 25% risk of transmission. So one drug in a pregnant woman reduced her risk of transmitting to the child by 2/3. So this was the first evidence that HIV treatment could also be HIV prevention. Of course, today we don't use one drug anymore, and a pregnant woman is recommended to take the same as anyone else with HIV. And if a pregnant woman takes standard 3-drug therapy, her current risk for passing to her child is less than 0.5%. So radical reduction by completely suppressing the viral load. And what that's done in our country is simply reduced the number of perinatal children who acquire HIV to almost none. So that's shown in the blue line here. You can see that the number of perinatal cases really peaked around the mid-1990s, and that's when this idea that you should treat pregnant women to reduce transmission started. And then you see over about 5 years' time that the number of cases is radically reduced. Today it's estimated that there are fewer than 100 children in our entire country born to HIV-infected mothers who have the infection themselves. So this is one of the big success stories in our field, and it's really the first evidence that ART treatment is also prevention of HIV. The next scenario where this was explored was ART to prevent someone who's HIV negative but exposed to HIV. And the first scenario that occurred was really occupational. So these were needle stick exposures that occurred in hospitals. A needle that had entered an HIV positive person and then due to an accident also stuck an HIV negative healthcare worker. And the number one group affected were nurses. That won't surprise you. So people looked early on and had the same idea. Well, if we could administer antiretroviral treatment to someone who was exposed on the job quickly enough, could we prevent infection from taking hold? Could we use the treatments again as prevention post-exposure? So the name post-exposure prophylaxis, or PrEP, arose from this. Again, first done on the job occupationally. And again, going back to the mid-90s, one drug, AZT, reduced the risk of a healthcare worker who had a needle stick injury from an HIV positive person by about 81% compared to healthcare workers who elected not to take anything. This wasn't a randomized study, it was called a case control study, but it's the only study we really have prospectively to look at this question. So it became widely accepted that you could use the HIV treatments in this post-exposure scenario. Recently, note the date here, just last month, the CDC has updated their post-exposure prophylaxis guidelines, their PrEP guidelines, for occupational exposures. And they recommend 3 antiretroviral drugs, and what was new about the guidelines is that they changed the drugs to ones that were easier to take and better tolerated than previous regimens. And it's recommended that healthcare workers take this following an exposure for 4 weeks, and that, given everything we know, is thought to reduce their risk of acquiring HIV infection. Well, pretty early on, people said, well, if it works on the job, what about off the job? So non-occupational post-exposure prophylaxis, or NPEP, was another strategy that has been looked at. Now, interestingly, we have no prospective data. The Fenway's actually collected a lot of observational data on the use of NPEP, as have other places around the country. And the same theory is here. After a serious exposure, if you come in with drugs quickly enough, can you reduce the risk of of infection really taking hold in these individuals? Note the date on these CDC guidelines, 2005. They really haven't been updated since then, although those are being worked on right now. most people would apply the newer occupational guidelines to the post-exposure non-occupational setting. So what they recommend, again, is 3-drug therapy for a serious exposure, taking the drugs for 4 weeks. And all of this is predicated on the idea that someone presents within 72 hours, so 3 days, of their exposure. That's extrapolated from monkey data, but it's the only data we have. And so these are the current data out there about HIV negative people who are exposed. So we have prevention of mother-to-child transmission, and we have post-exposure prophylaxis, 2 scenarios where ART is working as prevention. And then the big news came to find out that treatment really is prevention in another scenario, and this time it's targeting HIV-infected people. And we heard a little bit about this study last night. HIV Prevention Trials Network Study 052 enrolled over 1,700 discordant couples, so one's HIV positive, one's HIV negative, and they're in a committed relationship. 97% were heterosexual, and in fact, we're standing right here in the Fenway, which enrolled the other 3%, which were the only non-heterosexuals enrolled on the study. And these were in diverse places across the world, as you can see here. The HIV positive partner in the discordant couple had a CD4 count between 350 and 550. Why did they pick that threshold? Well, most of the world, at the time, they would not have been treated for their HIV infection themselves. And the primary question is, if we treat the positive partner with that CD4 count, will we reduce their risk of transmission to their HIV negative partner? And so it was a very simple design. The positive partner was randomized either to start treatment right away or wait until their CD4 count dropped below 250, which would be the threshold for their need for treatment to help themselves. And the bottom line was that the Independent Data Safety Monitoring Board found that there were 29 new infections that were linked to the committed partner. And when they broke those out, 28 of them occurred in the group that were not yet on antiretroviral therapy, and only a single case occurred in the people that had started therapy at a CD4 count 350 or above. And as was mentioned last night, a careful look at this case dated the time of exposure to the negative partner really the day the person started antiretroviral therapy. So the drug's really not on board long enough to prevent that transmission. If you do the math there, 96% reduction in transmission by treating the positive partner, and this made the headlines of the world's papers after these data came out and profoundly influenced the world. So a third way to use HIV treatment as prevention not only benefits the person with the infection, but reduces their risk of transmitting. The fourth scenario is, what do you do about HIV negative people who are at high risk for acquiring HIV themselves? And we've already talked a lot about this. Certainly counseling and condoms, as has been said, worked for many people, but doesn't work for everyone. And so new strategies have been explored. So 2 of them are listed for you here. Again, these are aimed at HIV negative people who are at risk for infection. One is microbicides. These are gels, creams, films, or suppositories, so many different delivery systems that could be applied either inside the vagina or rectum, and they should protect against sexually transmitted infections, including HIV. And then the other strategy is PrEP, pre-exposure prophylaxis, and the idea here is giving HIV drugs to uninfected, at-risk individuals to protect them from acquiring HIV infection. These were simply ideas. Now we have data where these have been used. The very first study to look at one of these approaches was the CAPRISA 004 study. And note the date here, it was only published 3 years ago, or 3.5 years ago. The study population were young South African women who were HIV uninfected, and you can see it was a big study. This refers to the total number, 889 women. They were randomized either to a placebo gel or a tenofovir gel, so a microbicide with the drug tenofovir inside the gel at a concentration of 1%. And the women used it before and after intercourse, and never more than 2 doses in 1 day. And here's what the results of the study. The primary endpoint was the number of new HIV infections. And this is expressed as a percentage here. So in the placebo group, over the time they looked, women who used the placebo gel, which should have had no effect, about 10% of the women newly acquired HIV. Compare that with the group that used the gel, and you see that that group, only 5% of the women acquired HIV. So that's a 50% reduction at the end of a year. So that's certainly a positive result. They continued to follow the women out to 30 months, and you can see there's still a significant difference between those who had used the placebo gel versus those who used the gel with tenofovir inside. People began to think again of using HIV drugs for prevention as PrEP. So asking people who were negative to swallow pills to prevent them from acquiring HIV. The NIH convened a working group and said, well, what's the ideal PrEP drug? What criteria would that drug have? And here's what they came up with. Safety, probably #1 consideration. We're not using these drugs for treatment, but for prevention. And so the threshold for safety has to be very high. Penetrates target tissues like the genital tract and the rectum. Protects against HIV infection in tissues. Well, that's why we're using the drugs in the first place. Long-lasting activity for convenient dosing. Now thinking about how would people actually use these. A unique resistance profile or a high barrier to resistance, with the thinking that if, as you use HIV drugs for prevention, you don't want to induce resistance in the community. No significant drug-drug interactions, possibly not a part of the current HIV treatment regimen. Maybe you use separate drugs for treatment than you do for prevention. And lastly, affordable, easy to use, and implement. So then you go back to the 28 antiretroviral drugs we use and begin to apply those characteristics. Many of these fall out as being compounds or drugs that just wouldn't be appropriate to use as a prevention. And the 2 drugs that rose to the top turn out to be TDF, that's tenofovir, or TDF and combined with FTC or M-tricidabine. And these, among the 28 drugs, are known for their potency, tolerability, and convenience as a 1-pill once-a-day regimen. So these really stepped forward as the PrEP candidates of choice, either tenofovir by itself, 1 pill once a day, or tenofovir and FTC together, co-formulated as 1 pill once a day. And the FDA approved that combination for PrEP in July of 2012. And this is the indication, TDF-FTC as PrEP in combination with safer sex practices to reduce the risk of sexually acquired HIV infection in adults at high risk. Almost every word of that indication is important. Now, why did they approve it? Well, it was on the base of randomized, large phase 3 studies. So let me review a couple of those. The very first one is the IPREX study. This was PrEP in MSM. HIV uninfected MSM or transgendered women were enrolled from South America, South Africa, Thailand, and the US. And again, Fenway was one of the sites for this study. And you can see it was a big study, 2,500 at-risk HIV-negative MSM and transgendered women. They were randomized either to receive PrEP or receive a matching placebo and then followed for who acquired HIV infection. It was found retrospectively that 10 of the participants were HIV infected at enrollment, had negative antibody tests, but were actually experiencing acute HIV infection. That wasn't known at the time. But when you look at the percentage of people who became HIV positive in each group, you see the placebo group here in red, 64 new HIV infections, compared with the group that was randomized to PrEP with the 2 drugs, where there were 36 infections. So taking PrEP was associated with a 44% reduction in acquiring HIV. Now, many people said, well, 44%, that's okay, it's not great. What's going on there? And it turns out that adherence is really critical. If you went back and looked at people who had drug levels measurable in their blood, which is an imperfect way to measure adherence because you could have taken the pill only 2 days before you showed up at the clinic, but it's one of the best ways we have. If you look at that group that had measurable drug levels, 92% reduction in the risk of acquiring HIV. And again, these results were published in major medical journals and presented. It was the first evidence that PrEP really worked. Now that went on, and in parallel, there were a number of other PrEP studies, and some of these led again to the FDA approval. The biggest study was the Partners PrEP study, over 4,700 discordant couples in Kenya and Uganda. So again, an HIV positive person in a committed relationship with an HIV negative person, but this time focusing on an intervention in the HIV negative person. And important to know that the positive partners were not on antiretroviral therapy. So large study, they got either tenofovir by itself, the 2-drug PrEP, or a placebo, and PrEP in either case was associated with a significant reduction, 67% to 75% reduction. So we've seen positive results in MSM. These are positive results in heterosexual discordant couples. Along with that was a parallel study in a smaller group of Botswanan adults, and showed similar results looking at the 2-drug PrEP versus placebo, a 63% reduction. And a completely different group just recently came out, Bangkok injection drug users. So the 3 studies I mentioned so far were sexually transmitted HIV. Here's a group of people with both needle sharing and sexual behavior. In Thailand, over 2,400 Thai injection drug users who had used it within at least a year prior to coming onto the study, randomized to 1-drug PrEP versus placebo, and the 1 drug associated with a 49% reduction. So you can see reductions in every group, and then you'll note if we do the same thing, if we look at people who had measurable drug levels, the efficacy of PrEP in each case is much higher, 86 to 90, 84, or 70%. So the IPREC study and the Partners PrEP study were the 2 that led to the FDA approval, and the TDF2 was a confirmatory study. The IDU study came post-approval, the results. Now, 2 studies showed a lack of efficacy of PrEP, and these were done in the same time periods, one called FemPrEP and one called VOICE. FemPrEP exclusively enrolled over 2,000 women in 3 African countries, had the same setup, but failed to show a reduction in HIV infection in the women that used PrEP. And coming a little bit later was the VOICE study, the biggest PrEP study ever done, over 5,000 women in 3 African countries. And they were randomized in a complicated schema to one of 5 options: the 1% TDF gel, which I showed you in the Caprisa study, a placebo gel, an oral PrEP with 1 drug, oral PrEP with 2 drugs, or a placebo. It turned out with this 5-arm study that the investigators eventually concluded that no study drug arm was effective among the 5. So why the difference here? 2 studies in African women failing to show efficacy of PrEP versus the studies on the last slide showing efficacy. And the answer is not completely known, but maybe adherence. And so what you see back in the FemPrEP study, overall adherence to the meds, less than 40%. And overall adherence on the VOICE study, less than 30%. It reminds us that you need to take drugs for them to work. We shouldn't expect that they would work in people that don't take them. But this is actively being explored. So the CDC has looked at all of these data and developed formal guidance. And they issued 3 separate guidances as the studies came out. So after IPREX, the CDC came out in 2011 with guidance for MSM about PrEP, heterosexuals after the Partners PrEP study in August of 12, and most recently, recommendations for injection drug users just this past June. Fortunately, the recommendations are very similar. What they say is document someone's HIV status and rule out acute infection. Because if someone comes into a study with acute infection and we give them 1 or 2 drugs, you will select for resistance. So we want to rule that out. They recommend the 2-drug PrEP therapy, tenofovir and FTC, 1 pill a day, and write a prescription for 3 months. Don't forget counseling, risk reduction, condoms, adherence, and drug use counseling. And then follow kidney function because of the potential for toxicity, although unusual, with tenofovir, and check their HIV status every 3 months. These are the formal guidance from the CDC. We honestly have no idea if they're being followed in the community at all. We don't know. Now, Gilead addressed a very interesting question, and that is, what is the PrEP uptake out there in the US? Lots of conferences like this, you hear anecdotal evidence that it's not really, people aren't really using it. But we haven't seen formal data until these came out. So this was presented at the infectious disease meeting ICAC just earlier this year. A national survey that represented 55% of US pharmacies, and they specifically looked for who's using PrEP, who's prescribing PrEP, and where is it happening. These data were referred to last night. They identified 1,774 unique PrEP users. The median age was 37, so really not the target group of people less than 30, although some representation there. And one of the big surprises from these data were nearly half of PrEP users were women nationwide. And then also surprising, I thought, who were the PrEP prescribers? Who actually wrote the prescription for PrEP? The most common group of prescribers were family practice, 16% family practice, followed by internal medicine, and really can't understand, emergency room MDs were number 3. Then comes infectious disease, nurse practitioners, and physician's assistants. So this was surprising. Who is writing PrEP prescriptions? And then also surprising was, where were PrEP prescriptions written most commonly? And you can see the place in the US that stands out. The region is the South at 32%, although I have to say I'm from Maryland, and I'm not sure we would agree with I'd sort of slice this a little differently here, but you can see the South, 32%, followed by the Northeast and West, and then the Midwest. These are the first data to really say, what's the state of PrEP in the US? Conferring with colleagues from Central and South America and Europe, they have no data, but they have the same conversations, and really the word from those regions is, quote, no one's using PrEP, which is interesting since we're all looking at the same data. What are the issues then in terms of ART for prevention? And I've covered some of the biomedical ones. Adherence is a biomedical and a behavioral issue, and Steve's going to address that. Side effects and toxicities, of course, can occur with any med. Tenofovir has been associated with renal toxicity uncommonly, and bone toxicity, reduction in bone mineral density, again, uncommonly. There are some side effects that came out on the studies, including nausea. Tended to be early on in the study, and then was not different as the weeks went by, but are concerns. Drug resistance, as I mentioned. Steve's going to cover the behavioral issues of adherence and risk compensation and others. And then a lot of what we're going to talk about today are simply the practical issues. How does one get access to PrEP? And that includes not only knowing where to go, but knowing who's going to prescribe it. A lot of talk last night already about providers being reluctant to prescribe PrEP, but realize what the problem is here. The people that know these drugs are the ones who treat HIV-infected people. The people who should be prescribing them may not be those docs at all. In fact, family practitioners, internal medicine, ER docs, they have a whole lot on their plate with every other disease, and are they comfortable with these drugs? In most cases, not. So how do you reach the group that's really going to find the people? The cost has already been mentioned, and insurance coverage, issues that we'll want to talk through this day. So my last slide is, what can we expect for the future of ART for prevention? And again, this has already been talked about. ART for HIV positives, there is consensus that this is a good thing, not only for the infected person, but as a tool to reduce transmission in the community. So increased testing, linkage and retention in care, access to the drugs, and being able to be adherent to them. And then ART for HIV negatives, as was mentioned last night, someone said, whatever happened to PEP? So how does one get PEP to the people who need PEP is a question we've been talking about for a while. The future of PrEP maybe less than 1 pill once a day dosing, so intermittent dosing being explored. Other antiviral drugs, so we do have 28, we're using 1 or 2. Ken mentioned that he and I are co-chairing a study looking at Maraviroc-based PrEP right now, which is of interest. And then long-acting formulations, drugs that you could inject that have detectable levels that go out 1 month in the case of an injectable rilpivirine, or a newer drug called 744, an integrase inhibitor, investigational, with levels in the therapeutic range 3 months after you give a single injection. So those are now in study both for prevention and treatment. And then microbicides have not been forgotten, so there are studies currently with both vaginal and rectal microbicides. So we need scale up, and we need to talk about that today. Demonstration projects and research projects ongoing. So I will stop there and say that HIV prevention, I think we all agree, is going to be a combination of things, and ART for prevention, an important component. Thanks for your attention.
Thank you. So thanks for everyone for coming today. It's really great to see some familiar faces and new faces. And thank you, Ken, for the very nice introduction. Except for one thing, decades, several decades that I've been doing this for. I was crawling several decades ago, right? Like, how could this face be doing things several decades? No. Okay, so let me just begin. So that was a great talk to come before, because I can kind of pick up on some of the issues that Tripp discussed in terms of why is behavioral science important when using ART as prevention, which is what Ken mainly asked me to discuss, and how can we address the psychosocial context when looking at HIV risk. And we have to kind of draw examples from ART as prevention as we'll draw examples from successful ART as prevention trials, but additionally, we don't have a ton of data on psychosocial issues for ART as prevention from PrEP specifically, and we need to draw from ART as treatment studies, as well as another biomedical agent that works almost 100%, which is condoms. So that, in that vein, one study from a few years back that Ron Stahl did showed the effect of syndemics on HIV risk in MSM. And looking at things like depression, poly-drug use, childhood sexual abuse, and partner violence, we see increased rates of HIV risk behavior and HIV prevalence. That's with MSM. Another frequent set of syndemics that we see among high-risk women or other communities are issues including mentally ill health, instability and homelessness, substance use, incarceration, and how they all are interconnected. We have a study that we're wrapping up now where we're enrolling patients with HIV and depression from Boston as well as Providence, and we see kind of this set of syndemics more in the Providence cohort and some of the first set in more of the Boston cohort. So in thinking about using PrEP for prevention or using ART for treatment, we do have to think about some of the issues that are really highly associated with high-risk behavior as well as self-care behavior. Again, this is just an example study from 2001 looking at the prevalence of psychiatric disorders among people living with HIV, and it's significantly elevated compared to national samples using a similar measure. And a big issue is depression, coming in at 36%, which seems to be the same kinds of levels that we see across different cohorts, including Africa. I was just in Mexico City, where I was at a clinic that serves, they say, 9,000 patients with HIV, and they're seeing similar kinds of rates there as well. So drawing again from ART as treatment, depression not only is highly prevalent, but it's also consistently associated with worse adherence to HIV medications. This was a study that at the time one of my fellows did, where it was a meta-analysis of 95 different samples, and there it is. We really found that it truly is associated with adherence or non-adherence. Looking at drug abuse, substance users also, if you're actively using substances, it's obviously, or you could kind of think would be associated with non-adherence, though we don't want to hold ART treatment for substance users, and there's data to show that individuals that do have a history of substance use are able to still adhere to medications, though active drug use is obviously associated with worse outcomes. But like I said, this meta-analysis here of 38 studies with 14,960 patients found that individuals with drug use had mean adherence levels comparable to general population samples. Another thing to think about when we're looking at models or psychosocial issues in ART prevention are the general models of health behavior change that exist for all kinds of health behaviors. And this is one that is very common. It's kind of parsimonious. It's the information, motivation, and behavioral skills model, which basically posits that you don't just need information to change your behavior, but you also need to have the motivation as well as the skills. And it makes a lot of sense. Like, we all know that we should be going to the gym 3 times a week, but not everybody does it. I was at a conference. I wish I took a picture. It was a large lung cancer conference, and in Barcelona. And outside, there was like this huge group of physicians that were smoking cigarettes. So it's a good model generally. But where it breaks down, and where we've seen it break down in terms of things like adherence to ART as well as condom use, is that when you look at the context, particularly in the things that I'm talking about, like mental health, what I'm using the word syndemics, or mental health problems that co-occur with each other, you could kind of see how things like depression, anxiety, I would add in poor social conditions, substance use. We could also add in things, I should have in there, things like poverty, disparities, stigma, all kinds of things that would affect in someone's daily life the degree to which they can kind of take in new information, the degree to which you'll be motivated if you do take in information. People, a lot of times, we hear that when you're looking at certain high-risk individuals, that preventing HIV or even treating HIV isn't really their top priority in life because they have so many other kinds of things going on. And this can affect behavioral skills and also health behavior. So this is just a slide to kind of graphically show that when you look at this particular model, but you can do it with basically all psychological models of health behavior change, how these kinds of contextual variables are really important to think about when looking at uptake to adherence to medications or basically any health behavior. Consistently with adherence intervention trials for ART as treatment, minimal interventions, things like we developed a study intervention here, which is a single session adherence intervention. We also did a pager study. Both had okay effects, but not great effects. And that was similar to some meta-analyses, so analyses of multiple studies that kind of showed that these adherence interventions for ART treatment are generally helpful, but modest. One intervention that we developed here at Fenway, cognitive behavioral therapy for adherence and depression, is where we took standard CBT treatment, which is an evidence-based treatment for depression, similar to the efficacy of antidepressants, and adapted it with adherence counseling. And we did that in the building that Ken showed, which was our first building in his slide where it said enter here in comparison to our building now. So it is, hopefully people here are excited about seeing this beautiful building at Fenway, but decades ago, we were in a kind of first floor basement of a subsidized housing building where we did this study and also, or the initial study, and also kind of where we were not too long ago. But when we took, in this case, just one issue that was confronting individuals with HIV trying to adhere to medications, and that issue being depression, we were able to see some nice effects. We monitored adherence with electronic pill caps, and we saw those improved in their adherence and their depression scores decreased. We also did this study in individuals with injection drug use, a similar trial, and here's how their adherence increased while they were getting this intervention compared to those that didn't get the intervention, as well as decreases in depression across the two groups. However, in that study, once we stopped providing the adherence counseling and the depression treatment, depression gains were maintained, but unfortunately adherence gains were not. We didn't see viral load differences, though strangely we saw CD4 increases in those that got the intervention compared to those that didn't. Dr. Gulick mentioned the HPTN 052 study. And I wanted to just make a little bit of a comparison between two studies that happened. Basically, they started off at around the same time. ACTG 5175 started as a treatment study to complement HPTN 052. As you recall, in 052 it was delayed, or not delayed, it was early initiation of antiretroviral therapy compared to standard of care. But to kind of complement that, ACTG wanted to do a treatment study for those that needed treatment. So there was a lot of overlapping sites. One thing about these two trials, which I would say is different than a lot of the PrEP studies, is that in these studies, the PIs were very proactive about making sure that behavioral science was included in these two studies. And Mike Cohn had me work on adherence counseling for the patients in 052, and that also happened in 5175, where we did some focus groups at selected sites, and we adapted our adherence counseling to train dedicated adherence counselors in each of the studies, as well as providers. And both studies were quite successful, as you heard. In the 052 study, early initiation really decreased HIV prevalence. And in this A5175 study, they were looking at mainly different regimens of ART, finding that once-a-day regimen was better than standard of care regimen. One of the standard of care regimens, it was three different regimens, but that's not my main point. One of the main point that I kind of wanted to make is when you look at some of the predictors of adherence, we do see some differences between the prevention trial and the treatment trial. In the treatment trial, which was 5175, in the psychosocial measures that we looked at, perceived health, so how poorly you, or how good or poorly you felt your health to be, was a predictor of adherence, such that the worse you feel, the more adherent people were in this treatment trial. Meaning, like, if you're feeling sicker, you take your meds more. Kind of like if you have a headache, you have a cue to take aspirin, whereas if you feel fine, you may not have the cue to take medicines. In the prevention trial, so some people may not have, by standard of care, needed treatment right away, so people in general were healthier. We see different predictors of adherence, and they're more kind of the typical predictors of adherence that we've seen generally, things like social support and mental health. Dr. Gulick also mentioned a bunch of the PrEP clinical trials, and that's nice, so I don't have to go over each of the different studies, but and the adherence findings as well as the HIV reduction rates. But what I did want to just mention is that you see, let's see, I think this next slide shows it. What we see is like really much better efficacy of PrEP when people are in fact taking the pills. And I think in the slide that you had shown with the drug detection levels, generally that's any drug detected, not necessarily that the drug were optimized. So even when you see, any drug detected, you see better rates in adherence. But what we don't have is like if people really are taking it every day. One way that we can kind of get at this is an ancillary adherence sub-study that I was part of in the Partners in PrEP Gates-funded study, which was in Uganda. Well, our sub-study was in Uganda in 3 sites. And what we did in this with David Bangsberg and Jessica Haber and my colleague Christina Saros is 3 study sites were selected out of the Partners in PrEP study for an ancillary study. And we monitored adherence in patients using unannounced pill counts. And they also did MEMS caps. And if people had low adherence through the pill count, less than 80%, they then triggered an intervention. So everyone who was taking PrEP were being monitored, and then also they knew that they would get an intervention if they had low adherence. And the intervention was, again, based on our Life Steps intervention that uses principles of cognitive behavioral therapy, as well as provision of information, while still tailoring counseling needs to individuals. So it says 12 modules, but it's not 12 sessions. It's 12 different things that you kind of can talk about in the intervention. And what we see in that sub-study was incredibly, I think, dramatic results. That the PrEP efficacy, when you get that whole package of adherence monitoring plus adherence intervention, if you drop in adherence, is that we have a 100% PrEP efficacy compared to placebo. There were 14 infections in the placebo condition and 0 in the participants who were on active study drug and got that package that I just mentioned. That's now published in PLOS Medicine with Jessica Haber as the primary author. Our intervention, this is just some of the characteristics. It was optional as to how many sessions participants would come to. And I do feel like I got a 2-minute warning here. I do feel like in some of the PrEP studies that adherence is added once the study kind of begins or halfway through, that people start thinking about adherence because they get worried that maybe the trial isn't going to do well because of adherence. And in some of the PrEP studies, there's kind of some battles among the behavioral scientists to really do sessions, and people are saying, well, participants aren't going to want to come in and do these sessions. And here we had, the mean number of sessions being 10. I did want to just mention some of the work that we're doing here at Fenway. We have a project optimizing PrEP. We call it Project Prepare, where we're trying to randomize patients. Everyone gets PrEP, and we randomize them to our intervention or not. These are some of the advertisements. These ones we got a little in trouble with. Actually, all of them we did. In terms of rollout of PrEP, we really do want to try to get people who don't always wear condoms and don't always use condoms, because we want to have people who are engaging in risk and aren't necessarily going to be candidates for just general condom use counseling. And we also need to kind of find ways to get high-risk men to come into the study. And using advertisements like this, what we found in terms of our advertisements is that guys don't click on the advertisement unless it kind of looks like that. But what we're doing in that study is that we have people put their medications in a pill dispenser, so we get real-time data on whether or not they're taking their pills. It's with called Wise Pill, and it's a kind of opens up what's connected to cell phone towers, as well as we're using text messages to look at unsafe sex and see if we can tie when they're taking pills to when they're having unsafe sex. So they get this automated text message survey every day. Is this a good time to take a survey? Please enter your PIN, so that like if they have a friend that's holding their cell phone, they don't get the next question. Did you have sex in the past 24 hours? Yes. Yes, anal. Yes, vaginal. Yes, both. 4, no. And then did you use a condom? And so people are getting this every single day. And what we found in our early experience with participants is that generally, actually, adherence is pretty good in this study where people get free PrEP. But also, the men are reporting continued high-risk sex with that assessment. So I think that what this is showing is that when you take motivated individuals who are high risk and they're prescribed PrEP, that we see continued high-risk sex, and we see continued, and we see pretty good adherence. So in summary, based on our experience with ART for treatment, I would just say that adherence is complicated, and interventions to promote adherence need to take into consideration the psychosocial context. So what I mean by that is when we do develop counseling interventions for PrEP, based on things that we've learned from condom use counseling and what we've learned from adherence counseling for treatment, that it's not going to just be a quick, brief, informational, motivational behavior change intervention to help people really make changes given the psychosocial context that many people are facing who are having a risk for HIV. And that's basically the summary of all the other bullet points on this slide. So thank you very much.
For a wonderful presentation, really informative and helpful. I'm in New York City, and we have recently done some focus groups, and one comment that came out, this is among Black and bisexual men, talking about treatment and what would help them link to care earlier, get into care earlier. And one comment really struck me, and I just wondered, particularly from a cognitive point of view, if you've seen this as well. They said that taking their medication is a reminder to them that they are infected, and that, you know, it's sort of part and parcel of the denial issue. If I'm not in care, if I don't take the medicine, maybe I don't really have this. But when I take the medicine every day, that in itself is kind of a negative trigger, because it reminds me that I have HIV and I have something I have to do that other people don't have to do. Have you encountered this? How have you addressed it? I'm just curious to know.
Yes, we've absolutely encountered that, and I would say even in our first study in 1997, when we started doing this adherence counseling, that was we measured what we called punishment beliefs about HIV medications, and that was a predictor of non-adherence, that people like look at the pill and feel like, oh my gosh, I've done bad things and now I have to take this. And in the intervention, that's one of the things that we try to do with people, is to get them to focus more on, we first ask them about the reasons that they want to be adherent, and reasons that they want to be on treatment, and reasons that they want to live. And we try to get people to slowly associate that with their pills instead of the negative reminders. It's tough, but that's part of, I was talking about cognitive behavioral therapy. That's kind of the cognitive part of the CBT that we try to do.
In clinical practice, this has been a theme since the 1980s, that everybody felt that way. And I guess my understanding of this, we usually try to turn it around and say, this is you taking control, taking that one pill a day, and you're actually fighting the virus every single day. It doesn't always work.
It's remarkable how persistent it still is. I mean,
Yeah.
many of the men said it.
Yeah, I agree with both were great presentations, but I have a question, because I think adherence is something with which we have struggled forever. Not only with HIV, with any other medical condition that we treat. And the thing is that with HIV has a total different implications. And while those methods are really great, how do you scale that up? I mean, and bring, something that is, somehow brief yet effective into the actual clinical practice? Because I was telling Greg, I have patients, and my patients, do really great, but I spend a lot of time with them, and I actually choose who I want to treat who. So how do you do that, more generalizable, in order to obtain, a more kind of a universally, successful, adherence?
So the question is about scaling up adherence in the real world where you have limited time and resources.
From the view of I'm a clinical psychologist, so we are used to providing individualized interventions, and I think the point that you're making is a real clash, I'd say, between what I'd say clinical psychologists believe about what is needed to really have someone who needs to make a behavioral change and is struggling with it and has all these difficulties with the public health need to do something that's going to be quick and it's going to be fast and effective, and how to scale up the resources. I don't feel like I have an answer. I feel like some of the very brief interventions, if you were to call them a behavior change intervention, I think they're not. They're more like informed consent, or they're more like if you can only spend 5 minutes with someone. I'm not sure how much that's going to solve all the contextual comorbidities that happen in the course of trying to make behavior change. I'm hoping that we can show some of our work is cost effective, that we can train and have things like adherence counselors like we did in the international studies in clinics, social workers or medical social workers in clinics that can have enough time to spend with patients that are having more difficulties versus, let's say, a subset of people that might benefit from a brief intervention, and then something more for people that need more. I don't.
From the clinical point of view, the answer is make it easier. So go from 20 pills 3 times a day to 1 pill once a day. Go to better tolerated drugs, and then that's why I think there's a lot of excitement about these long-acting preparations. People should have choices. So many people like 1 pill once a day, and that's all they want. Other people might benefit from these long-acting injections once a month or once every 2 or 3 months. I think that's where the field's moving.
Harry, you want to comment? I just have a thought or idea or a question. You don't have to answer it, but Stephen, you alluded to this in Blaine's comment talks about this.
Maybe you could stand up because our acoustics are so good here.
I'm tapping into the comment about context and then Blaine's comment, because I think what we're all seeing here is that it's more than about just behavior. It's about people navigating environments and social conditions that lead to these syndemics that we see in folks. So what should we be thinking about in terms of structural changes, on a bigger level that can impact behavior that might ultimately have a beneficial effect on the uptake and adherence to these approaches? If you have any thoughts on that, or anyone. But I think that's part of our problem.
Well, I don't know how to answer that. One thing I've begun to hear, which I have no expertise in, maybe others do, is that we have to market this stuff better. Yeah. You have to find prevention strategies that are sexy to people, that are easy, that are readily available, and that's when people are going to use them, particularly young people. How do we do that? People talk about microbicides, it's this gel. Can you make a gel sexy? Can you put some, I don't know. There are ways to do it. Fragrance or color or, I don't know.
The past 3 questions are very similar and following that same issue. And I think that's where we're really struggling, is how to do like a structural intervention that's going to reduce stigma, that's going to address these kinds of things. And that, I think, would really facilitate adherence. And we do here, we've done some focus groups. Wade Taylor back there with the beard, who's going like this, did some focus groups for us with another colleague. And these issues are what came up when we designed our PrEP adherence intervention. That if you see the pill, if a guy goes into someone's medicine cabinet and sees the pill, they either think that they're engaging in a lot of sex or that they are HIV infected and they didn't tell them, and partner issues. It brings up a lot, and I don't know if you guys have any other ideas, but it's just.
No, I mean, I think part of our intention today is to really get a lot of really bright people together to think about these issues. How do we change some of the community norms and dialogue? So these are really key issues. We've got a bunch of people and limited time. So what we're going to do is a lightning round. And sorry, can only do 3 people. So you, Peter, and David, and Rick. Okay, four people, and then Tripp and Steve will answer everything. So do you have all the questions, Steve?
I think so. Yeah.
Thank God.
So.
You take the ones you want.
All right. Trauma, I would put in definitely in the same issue of syndemics, and I would the thing that I also didn't focus a lot on, I think related to that, and related to the question about the messaging and using condoms, is that people aren't always going to be able to use condoms for a variety of different reasons. It may be because they, in a simplified way, have a history of trauma and are not focusing on self-protective behavior due to, long-time history of childhood sexual abuse or current trauma or current domestic violence. Having unsafe sex in different contexts to exchange for goods or services or things that people need, just trying to get by. We need to have agents that are going to be able to be used in those kinds of situations. Related to the low uptake and the ramp up being slow and the messaging of using condoms, it is a balance, and that's what we even ran into here. I would say if you were to look at the United States, like in your map, and you were to look at, liberal places of the United States, you're going to be focusing in on Massachusetts. If you're going to be looking in at all of Massachusetts and you're going to find like a liberal part of Massachusetts or a liberal gay-friendly health center in Massachusetts, it's going to be right here. And even here, a lot of our providers are reluctant to prescribe PrEP, and because they have this struggle in our ads that say don't always use condoms, they want people to always use condoms. And so, kind of getting to the point where, like our beginning of our data showed that people aren't necessarily increasing their risk and, using PrEP and letting their hair down, for those of you that are fortunate enough to have hair to let down. I mean, but they're not like kind of running out and I don't think increasing their risk, but using it for individuals that are probably not going to use condoms all the time, and facing that in a non-judgmental way is going to be really important. I think I got most of it except for the timeline. Oh, the Akazi and cost, but why don't you do timeline and then I'll come back to that.
Sure. The question about where the newer drugs for PrEP are in terms of development. So Maraviroc is in a phase 2 study. That's the one Ken and I are doing right now, which is pretty far along. And the injectables are at an earlier stage. Just the phase 2 studies are being designed right now and are planned. So everything is at least several years away to go. One of the challenges in drug development for PrEP right now is that the control has to be tenofovir FTC, and then you have to have a big enough study to show that you are either similar or better than tenofovir FTC, and those studies are going to cost millions of dollars and have to enroll perhaps thousands or tens of thousands of people. So in our current economy, it's tough to know how we're going to go into phase 3 with any of those. And then the other question I'll respond to is why the low uptake, and should we have expected this? I think in HIV in general, we are a healthcare community that does things really fast and are fast adopters. So everyone knows in the mid-90s, once triple drug therapy was announced as an abstract at a meeting, it became instantly the standard of care for the entire country, which was amazing. So we're sort of spoiled by that, I would say. We tend to be fast adopters. Prevention, drugs for prevention, or the birth control pill is a nice analogy. It takes a while longer and people have to be comfortable with it. And then the point I made that the people that know about this are not the same ones as the ones that should be prescribing it. Do we get everything, Ken?
Well, there was just the ACTG and cost effectiveness. And, I think what the data are showing is that these computerized interventions can be helpful, I'd say moderately, and for certain populations. But again, when you really are getting into some of the co-occurring psychosocial problems that people are having, it's hard to imagine that like sitting in front of a computer and answering questions and like doing some kind of automated thing is going to really solve those kinds of issues. And that's what we also have seen in, there was a computerized intervention for antiretroviral adherence that Jeff Fisher and others did out of University of Connecticut, which was a beautiful, really well done intervention that just basically did not work in terms of promoting adherence, except when they did sub-analyses on patients that attended the clinic at every visit that they were supposed to come to. Those patients who used this program, it did work for. So, I think it's just like we have to think of some kinds of things that will work for some people that are automated, and then a way to triage people that need more help into getting the additional resources. Texting, yeah, I think that, again, could be helpful. We're using it in our PrEP study now, but we'll see if it really helps for everybody.